Well, hello everybody, greetings to you. I'm Tessa Guttridge. I'm chair of the Young Dementia Network, and I'm very pleased to welcome Dr. Rumana Chowdhury, consultant neurologist, and Dr. Zumer Jawaid, consultant psychiatrist, linked in with the Young Onset Dementia Service in Leeds, and we're looking forward to understanding the benefits of collaboration. Thanks very much to everyone for attending today. It's good to have so many people sign up for this webinar again. Just a reminder to you that as attendees, you're not on video and or audio, but we would love you to use the chat function. So do run free with that. And we'll protect some time towards the end, at least sort of 10 or 15 minutes or so, for questions and answers, and we would very much like you to put your questions into the Q&A function so that we can find them easily when we come to that point. Before I hand over to Rumana and Zumer, though, we are going to hear from Lorraine, who's experienced some of the benefits of the Leeds collaboration, and we're going to hand over to Catherine in the background, who's going to start the film for us.
I'm delighted to be joined here by Lorraine, who supports her husband following his diagnosis of young onset Alzheimer's at the age of 58 in 2020. Thank you, Lorraine, for being here today to share your experience. So during this webinar, we're going to be hearing about the Joint Clinic for Young Onset Dementia in Leeds, which was where your husband received his diagnosis. How was your experience of the diagnosis process?
Well, right from the outset in 2017, our very first appointment at the memory clinic, they did tell us it was going to be a long process. It wasn't something that can be done quite quickly. My husband had to undergo sort of an initial assessment, and then he had many sessions with a psychologist. Over that period of time, it was like every month or something like that he'd go and they'd ask him a range of questions. He'd have to draw diagrams, things like that. But after the tests, the results were inconclusive. So we were told that they'd have to be repeated the following year. So they knew there was something there, but they wasn't quite sure. So we agreed we'd have them done the following year. While we were waiting for those tests to be repeated, my husband's symptoms did get worse. And due to the type of work that he did, an arborist, so, climbing trees, working with chainsaws, driving heavy machinery and things, he was put on medical suspension due to health and safety reasons whilst we got a diagnosis. In 2019, after having had the tests repeated, my husband was diagnosed with possible dementia, and it wasn't until he'd had further scans in 2020 that we was told he had young onset Alzheimer's and Parkinson's disease.
It's a long process to go through, a difficult time.
Quite some years, yes, because obviously we'd had signs, that something was wrong many years before that, but we always thought, oh, he's lost his keys, can't find his glasses, that type of thing. Yeah.
So why has it been so important for you and your husband to have received support from the Joint Clinic following your husband's diagnosis?
Well, for me, it's been an immense support. My husband's diagnosis is the first diagnosis the family's had any involvement in. We've not been around anybody before. So we wasn't fully aware of what was to come. And so that was quite scary. Furthermore, as he was diagnosed in the midst of the pandemic, we thought, crikey, we're going to be on his own here. But that wasn't the case. We were allocated an occupational therapist who we could contact if we needed any advice, or he'd check in with us periodically. He signposted us to various services and departments, such as welfare benefits, carers leads. He made a referral for my husband to attend the Dementia Hub, which he attends 3 times a week now. And he even supported us with an application for the Blue Badge scheme. He sent a letter in to support that. And I truly believe that had he not done that at that moment in time in my husband's sort of journey, we wouldn't have been, granted it at that stage. So in the beginning, he was like our first point of contact. He signed, as I mentioned, he did sign posters to various schemes. If we had any issues, he'd take that on board, and he'd go and talk to the joint clinic and get back to us with anything he needed to get back to us. More recently, we tend to have like this indirect access to the consultants. So if my husband's experiencing any issues, he's having a bad time, all I have to do is ring the clinic and explain what's happening. And then usually within a week, somebody, usually the consultant, so I'm very lucky there, calls me back. It could be that they're just giving me advice, just reassuring me. It might be try upping his tablets or decreasing a particular tablet. Or let's book an appointment in to come and see him.
That's amazing. That support.
Yeah, because when you're a full-time carer, you haven't got time to be ringing around this, department and that department. Waiting for him to get back, chasing up calls and that. And this joint working really cuts that out.
Yeah, it's amazing. And for you, knowing you have one person you can contact when you have a question or a concern, and you have the faith that they will follow up and get back to you is amazing for you to have that support. And thinking about this joint clinic approach and the experience that you've had and the support you've received since, what has mattered to you most during this time?
What's mattered to us most? I'd say the experience I've had is that I tell it once. And then the joint clinics, they communicate with each other, come up with a plan or do whatever they have to do, and they get back to me, and tell me what I need to do, if anything. So it's a really streamlined process, and I feel really lucky to be part of that way of working, and more importantly, that me and my husband benefit from it.
Yeah, absolutely. It sounds like it really works for you, and that gives you the
it really has. That's
great. Well, thank you very much for sharing your experience today. I think it's really important for us to hear how it's worked for you and your husband, and thank you for being here.
Thank you.
Thanks.
Thank you.
It's always so useful, isn't it, to hear personal experience of these different services, I think. And that phrase, telling it once, I mean, it's simple, isn't it? But why isn't it the case that it's more widespread? Not to take time and energy and draw on your emotions to say things repeatedly, and then that practical and emotional support that's offered. And I do feel that Lorraine felt lucky, didn't she? But and she is, and Rumana and Zumer are going to tell us more about how it works. But goodness, that should be the offering that everybody has, that sort of easy point of contact. But anyway, I'm really interested in finding out more about your service. So I'm going to hand over to you both now. Thank you.
Thank you, Tessa. Can I just check that everybody can hear me okay? Yeah. So thank you, Tessa, for and Young Dementia Network to give us the opportunity to showcase our practice here in Leeds. If Catherine, you could slide share, please. Thank you. So I think it is important for you to know that Rumana is a consultant neurologist working in Leeds Teaching Hospital, and I am an old age consultant psychiatrist, and I work in Leeds and York Partnership Foundation Trust. So we're two different trusts, and we have come together to come and deliver this joint clinic. Next slide, please. In the next half an hour, we're going to go through how it works, how the service works, and then how it was developed, service evaluations, and then what our future aspirations are. I think it is important to consider that young onset dementia, it is kind of, it's seen quite different memory services across the country who see young onset dementia patients. The service is structured very differently. It varies across the country. So what we know is that neurologists and psychiatrists work in silos, and it is that some areas see young onset dementia, it's more of a neurologist's business, whereas in other parts it is under a psychiatry service. We also know that patients who have suspected young onset dementia can see 2 to 5 different consultants before they get a diagnosis of dementia. Plus, we know that it can take a lot longer, more evidently in patients with FTD or rare dementias. What we know is that on average, a patient with young onset dementia, it can take 4.5 years to get a diagnosis of dementia. Here in Leeds, we have the best thing within our team, which is a cognitive neurologist in the form of Rumana, who works with us. So it allows us to bring the assessment and care of patients with suspected young onset dementia together, and we are able to give them accurate diagnosis and timely diagnosis. So next slide, please. So the bulk of our referrals is from GPs, and what we do is we encourage them to look out for any reversible causes of memory loss. Also, if there is any potential of recovery or rehabilitation, then we encourage them to address those things first. So, for example, a patient who has recently had a stroke or head injury or recent surgery, alcohol misuse, these are all sort of conditions where people can get better and may not develop dementia. So we try and want to address that in the right way. There are other conditions like hormonal problems. So we know menopause, thyroid problems, or functional mental health problems like depression and anxiety. So we would really encourage them to see to all these problems before they refer to us. I would say that this is not a barrier to access our service. Instead, this is to avoid any unnecessary anxiety for our patients and getting them the right care from the outset. So once they've been referred, we go through a screening process once a week in our MDT. And then if we have all the information, we will decide where to go next. And one of the things could be a joint clinic, or it could be a team assessment, or an assessment by a doctor. It is during that process that we sometimes identify patients who've also been referred to Rumana, or they need input from neurology, and we'll send them off to the joint clinic. We are a small team, so we have few doctors, part-time, 2 nurses, 1 occupational therapist, a part-time neuropsychologist, and a clinical team manager. Next slide, please. So once they're assessed, there's a lot of advice and guidance work, which happens at triage, but also happens once they've been seen. So we would identify people who need other services, and we will signpost them to them or refer to them and discharge. An example of that would be patients we see with sleep apnea, and then we refer them on to sleep clinic. There are other patients who we would have assessed, and then we get concerned that they may be developing a dementia process, or we do want to investigate them further. We then think about further investigations, so that could be in the form of imaging, CSF analysis, neuropsychology assessment, and then they go through a robust assessment process. So we then are able to diagnose them. Next slide, please. So once they've had a diagnosis of dementia or mild cognitive impairment, they go through a comprehensive post-diagnostic support. I want to mention Leeds Dementia Hub, which is part of Community Links. It is managed by local authority, but we are so lucky to have this valuable service. Lorraine's mentioned how important this service is to her, because she gets a 3-day relief, you know, with her husband attending the hub. But I also have, or the team also have, got close links with Leeds Dementia Hub. So once we have got someone, we almost always refer them to Leeds Dementia Hub. I can also reach in Leeds Dementia Hub for BPSDs or complications of dementia. I also have clinics in Leeds Dementia Hub, and these are for, again, more complex, challenging patients where either they're struggling to engage with the assessment process, or they're struggling with the diagnosis of dementia and its complications. So depending on which stage they're at the time of diagnosis, they may require some extra help, so we can refer them to adult social care once we believe that all their needs are met. And also Leeds Dementia Hub provides us that reassurance, that contingency plan, that if they are attached to Leeds Dementia Hub, we're good at discharging them because we have these direct links with them, and they can contact us and get us involved again if required. So that enables discharge as well. So once their needs are met, we discharge patients back to the GP, them knowing that they can come back to us whenever they require. Next slide, please. So this is the best part of our service. It works being it practically a monthly clinic, and it is Rumana and I. We do this clinic once a month, and we have almost always a visiting trainee or a different consultant or a health professional who is shadowing the clinic, wants to see what kind of patients we see and how this works. We have time for patient assessments and shared care reviews, and I'm going to talk a bit more about it in the next slide. We give 1 hour for our new patients and 30 minutes for follow-up. And then we've structured it that we have the additional discussion time. So next slide, please. So with the patient assessments, we know that these are complex patients who require neurology input. So we have identified them during triage or screening process. They could come from Rumana as well. So, you know, we have identified them quite carefully, who is the person who would require this kind of assessment. It helps us to accurately diagnose these patients. It's very important for me as well to see when we're discussing about the choice of imaging, and Rumana would have that knowledge of what imaging they've already had, what it tells us, and I'm able to learn that from Rumana. It also gives the patient that opportunity to get referred for lumbar puncture, CSF analysis straight away from that clinic. As I've mentioned before, that we are two separate trusts, so we have different recording system notes. We also have different neuropsychology. So the neuropsychologist I've mentioned before is LYPFT, and here we have the ability to refer people to Leeds Teaching Hospital neuropsychologists. And that's important because they are experts in brain injury and patients who are presenting with multiple medical comorbidities. Once the patient have had a diagnosis of dementia and we need to refer them to genetics, again, that's facilitated very well in this clinic through Rumana. This is the sort of thing we address when we're seeing the patients, but in shared kid reviews, this is an MDT that has Rumana, myself, and anybody else who's present in the clinic. And what it allows is, so any questions which we have had from screening or triage, I can bring them here. Any diagnostic challenges that I have seen patients individually, or my team has seen those patients, I can come and discuss them with Rumana over here. It also helps us manage the complications of advanced dementia, such as myoclonus, epilepsy, or Parkinsonism. And I can get that direct sort of advice from Rumana where to go next. And because Rumana or myself, you know, we will have that background knowledge, it just helps to cut out all the extra steps which otherwise we would have taken. For example, ask the GP to refer them to neurologist, then they sit in a waiting list, and then they get seen by a neurologist and a different neurologist who doesn't know them, and you know that get the treatment. So it kind of cuts out all of those extra steps. Next slide, please. So this I've just put some of the examples of the kind of patients we would see and their outcomes. So it gives us a flavor of the complexity, and most patients who I and Rumana would see together would end up with a dual diagnosis. So for example, you know, Alzheimer's and multiple sclerosis. So it does reassure us that we are able to look at it in a different way and provide a better service. Next slide, please. Moving on to service evaluation, I am very grateful and thankful for my high trainee, Dr. Shekhar Natarajan, who was working with me at the time and was able to lead the service evaluation for this team. We looked at April 2022 to April 2023, and I know you can think this is going back a few years, but this was deliberate so that we could see how long it takes for us to give people diagnosis, because we know it can take years. So we looked at each and every referral that came through the door and saw them through each part of the pathway. We received 475 referrals, and we provided advice and guidance in 277 cases. We were able to signpost them to a more appropriate service and discharge them. Next slide. So the team accepted 198 referrals, half of which we carried out the triage for. And while it does give us some extra information, it also helps us make the decision how quickly we need to go and see them. So again, 25 patients from those triaged patients were signposted elsewhere, and we ended up seeing 131 referrals. Of 131 patients, 104 were diagnosed and 42 patients were given post-diagnostic support. I've not put down the breakdown for diagnosis, but I can tell you that 30 of those patients of the 104 were given just a diagnosis of Alzheimer's or mixed Alzheimer's dementia. And then there were some patients who were given diagnosis of FTD, vascular, Lewy body, etc. And then about 2/3 of those patients ended up having mild cognitive impairment. Next slide, please. So what we were able to see in terms of timescales, that it took about 4 months for us to see the patient. And you can see that the range says that it's from 3 days to 498 days. So the 498 days, that number indicates that there have been some patients who were very difficult to engage and lots of DNAs and cancellations, which meant that it took us a long time to see them. And there have been few lost to follow-ups during this process, so we have identified them as well. The average time to neuropsychology assessments is 8 months. And this also involves a referral to LTHT, Leeds Teaching Hospital Neuropsychology. And it is under-resourced, and you can see it can take almost a year in some cases. We were able to diagnose people from the time of referral in 8 months, and the longest it has taken us to give a diagnosis is 18 months. The average time to post-diagnostic support has been 44 days, and again, there's some work where we could improve. Next slide, please. So, Rumana, over to you.
Right, thanks so much, Zumer. Hope everyone can hear me okay. So, Zumer's really nicely explained the Leeds Young Onset Memory Clinic service, and within that, the joint clinic that we do. I just wanted to give you a little bit of background about me as well, and then we'll talk a little bit about the pros and cons of our joint approach. So I am a neurology consultant, and I work in a different hospital trust. So as well as doing general neurology clinics, when I joined Leeds almost 10 years ago now, we didn't have any cognitive neurologists at that time, so I set up a cognitive neurology clinic. And so it was slightly different to the memory clinic service in that we would take referrals from anywhere, as we would do in our general neurology clinics, with no specific exclusion criteria. And what this means is that I do get some referrals from general practice, but also it's perhaps skewed slightly differently in that I would also get requests for second opinions, or people being referred from another region where a specific young onset memory clinic doesn't exist. Next slide, please. And so we had a little look at our data as well, which I'm very grateful to our medical student, Hannah, who collected this data. And so the numbers are much smaller, but it's quite interesting that the spread of what I see in the neurology clinic mirrors both what Zumer sees and what I'm guessing a lot of people see in your memory clinics. So the average age is a bit younger. The most common diagnosis is dementia, and of that, it's mostly Alzheimer's. I do see other types of dementia as well. So there's the behavioural variant of frontotemporal dementia, the language variant, so the primary progressive aphasias, people with Lewy body dementia and vascular dementia as well. And then the other 2/3 of people, again, I think this is similar to what Zumer sees as well, are people with cognitive difficulties in the context of other conditions like epilepsy, or multiple sclerosis, and those can be quite difficult sometimes to disentangle from another dementia, and also people with subjective and also functional cognitive symptoms as well. Next slide, please. So through doing my cognitive clinics, what I very quickly realized was missing was the multidisciplinary approach. So through my training as a neurologist, I'd been lucky to be able to sit in on lots of different sorts of memory clinics in various parts of the country, and I'd seen lots of different ways of working. And it was very apparent to me that without other specialists involved, it was going to be difficult to get to a timely diagnosis with someone, because as again lots of people here know, young onset dementia can be more tricky. The presentation can be atypical. Sometimes early structural brain scans like a CT or an MRI might be normal. So there was a real need to be able to discuss cases with someone else. And also, of course, you know, I'm not a psychiatrist. I have some experience, but I would find it difficult if someone had a comorbid psychiatric condition, for example, or what the impact of someone's depression was on their cognitive function. And so my sort of hope was that we could try and I could try and set up a clinic with other people in the region that could bring together the expertise of different specialists. And that's really what led to our joint clinic. So in the first instance, it was myself, another psychiatrist and a psychologist. And the idea was that we, myself and the psychiatrist, did the assessment of the patient together, and then the psychologist would be able to do some cognitive testing in real time, and then we would discuss the case and possibly give someone a diagnosis there and then, if that was possible, or at least discuss the management plan. And that's now evolved to the service that Zumer has described to you. Next slide, please. So I think probably the most useful thing is the chance for us to reflect on whether this clinic works and how it works, what we gain from it and what we could improve. So, for me, two heads are better than one. So to bring together two people who have, we've trained differently, we have skills in different things, but we are both interested in the same endpoint, to bring those together is really helpful when it is difficult to make a diagnosis for the reasons that I've already discussed. And nowadays as well, there is sort of increasing access and information about biomarkers, so other tests you can do that might help with the diagnosis. And having two people to think about that and try and work out whether a biomarker is needed or not is useful, because we don't want to be doing unnecessary tests, but also the ability to then interpret those biomarkers. So as a neurologist, our service is already quite geared up to a lot of this sort of thing. So we have regular meetings with neuroradiologists who look at scans. We have regular neurogenetics meetings. We're quite used to doing lumbar puncture testing and interpreting the results. So being able to bring that into this service, I think, has been very valuable. The other thing that we've sort of tried to highlight as we're going through is that we work in different trusts, and what many of you will know is that it's hard to access notes and records and information about people when it's outside of your trust. So what this means is that when we're seeing people together, Zumer can have a look at the mental health records, I can look at the medical records, and not only that, but we can interpret them for each other. So Zumer knows I'm not a cardiologist or an endocrinologist, but I'm a bit more familiar with medical tests, because that's how we work as neurologists. So I can help a little bit with that, and vice versa with the mental health records. So being able to do a lot of this whilst you're seeing someone and assessing someone is really helpful, and it just helps to push your thinking along and hopefully do things in a more timely manner. Would you agree with that, Zumer? I don't know if there's anything else you wanted to add at this point.
Thank you, Rumana. I would second that, what Rumana said. And also, for me, it's having that access to yourself, and I can email. So I know we've talked about how it's structured, but also there is a lot of informal discussion that happens in the background. I'll email you about someone who I'm worried about. Equally, if there's a patient you feel more comfortable accessing your service because you're not a mental health service, they would contact you and you would signpost them back to us, and then we'll go and see them from a sort of post-diagnostic point of view. So that works really well. Another thing which I'd add is that it is because we work with you so closely, it gives us the confidence and competence to not have a lower age limit to our referrals. So we don't have a criteria to say, well, you can only refer until the lowest age we've come across is 33 years old. So, that again, reducing those barriers is really important for both of us. There's another example, I'd say, where a patient and the family member didn't take on the diagnosis of dementia, and we'd seen them together separately a number of times to give them the diagnosis of dementia, which we confidently were able to diagnose. And then that joint approach in the end did really help them take on that diagnosis and ask all those questions about amyloid PET scans and things like that, which they had read upon and said, well, you've not done that, so how do you know? And having a consultant neurologist say, almost having two opinions from the team, it really helped the patient accept and receive support from our service. And I know I can talk loads of such examples, but I'll let you get on, Rumana.
Thanks. Yeah, I remember that. I remember that patient well. Yeah, the other thing just to say on this slide is in terms of post-diagnostic support. So, my neurology cognitive clinic is just me, but of course Zumer is embedded in a whole team which provides really post-diagnostic support, that the most important thing alongside a diagnosis with people with young onset dementia. So I think the thing to say again, as neurologists, we don't really have very good links with the community. So that's often quite difficult or long-winded for us to assess. We often have to go via someone's GP, for example. Whereas Zumer, although she's working within the memory clinic service, she has a lot of knowledge and good links with, community mental health and understanding how community services work. So being able to link into that more directly and use Zumer's triaging system to work out, who's going to be able to provide the most support for a patient and their family has been invaluable. Okay, next slide, please. I'm not going to do time, sorry. Okay, yes. So I think the other thing is just maybe just from a more personal point of view, really. I'm sure it's very apparent. Working together has just helped our own learning and our own development. It means we're able to see more complex cases, more tricky cases, discuss between us what they might mean, and learn from that. And I think it's been a really sort of human way of integrating services. This term is bandied around a lot within the NHS, but actually this is something that's developed in a really sort of human sort of way, rather than just coming up with a pathway of trying to link services together. We've just sort of got on and done this, and through doing that we've tried to work out what does work and what doesn't work, and what we can improve and how we can develop the service further. So one of the things we're looking at is access to biomarkers, so things like amyloid PET scanning. Where does that fit in the diagnosis process? How can we deliver that to people? So I think this joint approach has led to a huge development in our services, and is allowing us to try and keep up with all the developments that are happening in the world of dementia. And the other thing just to mention briefly is research activity as well. It means that we are more confident taking on research projects. We know we between us have a lot of people with different types of dementia who might really want to take part in research, and so we've been able to start doing that a little bit more now as well. Is there anything else to add for that, Zumer?
I'll just say, Rumana, you're being humble about all this. It is your idea, and if it wasn't for you to have follow through this idea, we wouldn't be here. And I think a lot of credit does go to that just one idea, and just two consultants working together. No pathway, no operational management involved. Nothing else. It's just it does sometimes scare me that it is one person who is leading on this, and I think in the future I hope that we can bring along more people, and that's why we open this example to anybody who wants to come along and watch us do what we do. So yeah, thank you for being there.
Next. Thank you very much. So yeah, I mean, so we can always benefit from doing more of this, I think. It's just trying to fit it into our job plans. But as Zumer says, you know, if more people are interested in doing this, then you know, it doesn't have to just be the two of us. You know, more people can start to do this, so we can grow the service in that way. I've said here streamlining, and what I meant by that was just, you know, maybe we can think about pooling together the patients that we're seeing in a slightly more structured way. So, for example, you know, this week we're going to talk about all the people who've asked about genetic testing and which of those people should we see and do genetic tests in, who is it not relevant for, and you know, how are we going to communicate that back? So perhaps we could do that a little bit more. I mentioned at the start we did have a psychologist sitting in with us, and again, a lot of this is due to sort of funding and practicalities and time. But you know, perhaps we can think about having some more people there in real time. Although I must say, you know, often we'll get a knock on the door from one of the neuropsychologists whilst we're doing the clinic to tell us about the patient that we're seeing there and then, or one of the nurses will come, and it's just brilliant, really. So it's a very sort of open service, I think is maybe the way to say it. Yeah, and we're very keen to be, it's not just two doctors kind of thing sat in a room making decisions. It is a team-based approach. And then this identification of work. So I think it's, you know, sometimes GPs refer to both of us at the same time, but I think through Zumer's triaging, you've been able to pick up a lot of that and sort of avoid duplication. Does that sound fair? Yeah, I agree. Thank you, Rumana. Next slide then. I will hopefully do it. So yeah, I mean, this is the last slide really, and then we're just really looking forward to questions and ideas from yourselves. So I think it's very obvious to see how this joint approach through neurology and psychiatry is going to be really important going forwards. I'm sure most people here have heard about the new treatments for Alzheimer's that are most likely coming our way with the monoclonal antibody drugs. So, you know, being able to, first of all, work out who might be eligible for these treatments is going to need a joint approach through neurology and psychiatry in terms of who these treatments might be safe for, making sure we've got the diagnosis right, do we need to do any other biomarker testing, and then actually delivering these treatments. So, you know, how are we going to do that safely and monitor it? And again, you know, for example, in neurology, we're quite familiar with giving these sorts of treatments for other conditions like MS. So can we bring those experiences to the memory service? And already we're having lots of, you know, interesting discussions between neurology and psychiatry in general, just about how we can group together and do this for people in Leeds and our region. I mentioned already we're having a look at some other things we can develop, like access to amyloid. Again, you'll have heard of potential blood tests coming for Alzheimer's and things like that. So all of these things, you know, none of these tests are gold standard on their own, and we've got to work out who they're suitable for and how we're going to understand what they mean. And again, I think having two heads together, myself and Zumer, it really helps trying to understand these developments as they become available and who they're suitable for. And then I think, just from my point of view, just the last thing to say really was that 2/3 of people who don't necessarily have dementia, so people who might have mild cognitive impairment or MCI, you know, can we maybe use this approach to help those people? Can we identify who's at slightly higher risk of developing dementia? Can then that work in terms of identifying who might benefit from treatment? And again, it is this sort of dual approach that is going to help us to do that. I'm conscious I'm probably getting to the end. Zumer, did you have anything else you wanted to add?
No, I just would say that it also provides our patients to the wider MDT, which you've mentioned in neurology. So if we both get stuck, then we have got access to that wider MDT both ways. So yeah, thank you.
Brilliant. So next slide is just the last slide. So it's just to say thank you very much, everyone, for listening. We're really interested to hear about how other people work across different regions and things you think we're doing well, things we could improve. So thank you very much.
Thank you, Rumana and Zumer. That was great. There's lots and lots of praise for the service, how effective it is, and the simplicity of it in many respects, being based on your relationship together, and just getting on and doing it, really. That's been really good, and people are finding it very inspiring as well, and want it to be replicated immediately in their own areas. So can I move straight to the questions? There will be quite a mix here, so and it won't be in any particular order. So we'll need to jump. So question, you mentioned amyloid PET scans. Are they a consideration from the outset for obvious patients? How far down the line would someone be before having such a thing, if that's part of what you do?
So
I'll let you take that, Rumana. Yeah.
Yeah, no problem, that's fine. So we don't have access to amyloid PET on the NHS yet in Leeds, so that does affect the way we think, I suppose. So no, we still follow a fairly sort of standard routine for diagnosis. So cognitive testing and assessment by ourselves, and a structural scan, either CT or MRI. If that's normal, then we are very lucky that we have a very experienced nuclear medicine department. So we do FDG PET, and the people in that department have published quite a lot on PET in Alzheimer's and FTD. So, and again, we've got a really good working relationship with them. So we often talk to them about results and things so we can understand them better. So we would do those things first, and obviously not everyone needs a PET scan anyway, but that's the sort of order that we do it. And then if we get to that point and we are suspicious someone has Alzheimer's but the tests have been normal or inconclusive, then we think about additional biomarkers. And at the moment, for that, for us in Leeds, that's CSF testing for amyloid, but that would be where the amyloid PET would come in, I think.
Okay, thank you. How many patients are you able to see at each monthly clinic? And I'll just add this is from Birmingham, Sally. Joint clinic. They have a joint clinic with Neurology and Psychiatry, which is also monthly. But we can end up with a long wait for the clinic. We have a neurocognitive MDT, multidisciplinary team on Teams, and that's also monthly to discuss for advice. But we find it difficult to avoid the build-up of waiting time for patients. Any advice there?
So I'd take that. We see about 3 to 4 patients, and that's not a lot. But if I am conscious that someone does need Rumana's input, but they will be waiting for a long period of time, then one of our team members or I can see them first, and then we can bring them up, which also means that rather than giving them an hour appointment, we can see them in 30 minutes because you can do the screening cognitive testing beforehand. So yes, that's how we would do it.
We do discuss a lot of patients in addition to that, I think is the other thing to say. There's a lot, I'm sure you've gathered, there's a lot of backwards and forwards.
Yeah.
And with my neurology cognitive clinic, sometimes I might be able to put someone in there and see them first, and then we can see them together. So we both have a little bit of flex as well, which is good.
Yes, lovely. Thank you for that. Fabulous example of clinically led collaboration. Have you been supported by your organisations in the use of shared resources and practicalities, such as information sharing agreements?
Yes, Rumana has got an honorary contract with LYPFC. I think you got that in 2020 when I started. Rumana, your manager's quite happy for you to carry on this input.
Yeah, they've been remarkably supportive. I think because this idea existed beforehand, that it was hard to speak to another team in another trust, and it was often you're going via lots of other people. So I think they're very, they understood that we needed to improve that. So yeah, they've been very supportive about that.
This one, the next couple are about roles. One is about what the OT role is in your team.
Zumer,
So that's so we have an occupational therapist within our young people with dementia team, and they can provide assessment, occupational therapy assessment, and also the post-diagnostic support. So like in memory services, you would know that patients where you're struggling to see whether they are able to function, whether they are able to sequence the tasks, and there is an AMPS assessment, I think, that they were able to carry out. So this is an occupational therapist who's been working in the team for more than 20 years. He is able to do the assessments as well as post-diagnostic work. So Lorraine's given an example of Blue Badge. You know, they can help with the other type of work, entitlements and PIPs and lots of you know, other practical things which can, and sometimes we'll send our occupational therapists out to say, if you could see what equipment they need at home, how are they managing that, and so on. So yes, it is a valuable service. I'd mention his name is Jonathan Gond, and also he is the main person who would carry out the triages. He likes to do that kind of work, and because he's so experienced, he does a great job. So yes, thank you.
Yes, thank you. And this is another one about a role. Is wondering if there's a role for radiologist or neuroradiologist to enhance the working of the joint team.
Yes, so in our neurology department, we have a weekly neuroradiology meeting. So they're quite happy for me to discuss scans from patients that perhaps I haven't seen, but maybe Zumer has seen, or someone else in the memory clinic service has seen and discussed with me. So at the moment we're doing it like that. I think if the new treatments for Alzheimer's come online, we'll probably look towards that being maybe a separate sort of memory or type of MDT with a neuroradiologist on it. But yeah, at the moment we just use the sort of existing neuroradiology MDT that we have already.
I also it's again thanks to Rumana that we have that link with our neuroradiologist. So sometimes I would contact him directly via email and say, what do you think, is that a good choice of imaging? We've discussed, and we want some advice on that, and he's very responsive and would help us out.
And I'd say actually we've been very open with our neuroradiologists, so sort of telling them about the way we work, and they really welcome it. Actually, they want to be doing the right scans, and all the information they get helps them interpret it better. So they've been on board with this way of working as well.
Great, thank you. So this is from a GP practice in Leeds. What is your most common rejected referral, and what's the reason for this? And the idea around this is to get a better understanding of the scope of your service and the kinds of referrals that you want and the kind of referrals you don't want to receive.
There is a big piece of work which we did in 2021 with our Leeds GP, and we came up with this sort of a criteria and how to refer, and we use something called DART referral system, where they talk you through when you are making a referral. That software talks you through. It is a contentious issue. I know I'm here in Young Dementia Network Forum, and the majority of the people that get rejected are the people who are drinking alcohol to more than excessive amounts, so heavily intoxicated, or excessive drinking, because we send them back and say, please tell them or advise them to go to the sort of the rehabilitation unit, or we call it forward leads here, where they can be referred to help them come off alcohol. So that's the biggest, I guess, rejection. The other one would be mental health, functional mental health problems, depression, anxiety, psychosis, which may have been missed if they weren't seen as face-to-face in, when they are having a GP consultation.
Yeah, yeah. Thank you. This one's sort of a comment, really. Demonstration of training gaps in psychiatry and neurology. It would be so helpful for senior trainees of each speciality to have cross experience. Maybe both colleges should work on it. Also highlights the obstacles put in place for early diagnosis and help due to psychiatry being placed out of general hospital trust. Have you got any comments on that? It's a fair point, isn't it?
Couldn't agree more. I mean, even my sort of fellow neurologists, a lot of them would never have sat in on a memory clinic during their training. Training is often guided by what you're interested in. So I was quite lucky in that respect. But yeah, I think it goes both ways, really, doesn't it? We do a lot of teaching, and we do try and encourage trainees of lots of different specialties to come and sit with us. So we have people from elderly medicine, neurology, psychiatry, lots of different backgrounds, so that we can try and help a little bit with that. But yeah,
yes,
I agree.
More to do, I guess, but not all on your shoulders. What do you need from the GP? What do you need for the GP to have done in order to refer? So is it useful for blood tests and such like to be undertaken by the GP?
So we would ask the GPs to carry out dementia screening bloods. So that's a must, like any other memory service. And also a cognitive screening tool. Doesn't have to be elaborative. It can be the commonly used 6 CITs, GP cog, and a bit about how it's affecting them. So, and also that they don't have any other medical problems. So for example, someone who has diabetes, and then once you do the bloods and you find out that they are either untreated or not fully optimized, then we'll say, can you please do that first, and then we'll come back.
Yeah.
Another example was of thyroid function tests. So when they come back and then they are abnormal, again, we'll ask them to treat that first and then send it back to us. So we do say that if you remain concerned about them, don't wait 3-4 months, 6 months. Let us know, send them back. We'll be happy to see them.
Okay, thank you. Thank you very much. I've got one quick one. You mentioned referrals from sort of beyond, so external to your own area. Have you got any notion of the numbers around external referrals and where they're coming from? Are there specific areas that they're coming from?
Yeah, I haven't got exact numbers to mind. I think almost half my referrals will be from other specialists, and the bulk of those will be outside of Leeds, just because we're quite a big neurology department. So it's just
right.
So I mean, it's not too far afield.
No, I see. No.
So
we did have one from Wales.
Yes, that one from Wales. Yeah. So it's maybe some of the other Yorkshire regions, all kind of between Yorkshire and Newcastle sort of way. For me, that's always very difficult, because it's often that someone just doesn't have a young onset service anywhere.
Yeah.
And that's when I'm then having to sort of use what I learned from Zumer's post-diagnostic team to try and help guide that support. So that needs a bit of.
Okay. Well, we're back to Lorraine, who described herself as lucky being in Leeds and being with the both of you. So thank you very much indeed for this webinar and for answering all those questions and explaining the Leeds service to us. Of course, we will be sending out the presentation, the recording, and any additional information that we think that will be useful to people, to all attendees, and very happy to share the chat with Rumana and Zumer so that you can pick up all the very encouraging comments. Our next webinar is Tuesday. It's a Tuesday this time. It'll be Tuesday, 16th of July, and it's Dr. Clarissa Giebel, and she's presenting on misdiagnosis. Misdiagnosis being really quite a big issue in many areas in terms of young onset. And that being one of the reasons for delay. So really look forward to the next webinar. Many thanks to Rumana and Zumer, and you'll find a sign up for the next one on the follow-up email. Thank you very much.
Thanks, everyone.
Thank you.
Thanks. Bye.